Well, welcome back for the afternoon session today. We're about halfway through. My brain is full. I don't know how you all are doing in that regard. So I'm really excited that we're going to start the afternoon with a talk on HIV and aging with a specific focus on neurocognitive impairment. And it's my pleasure to introduce Meredith Greene, who's an associate professor at Indiana University. She's a geriatrician and a HIV specialist, also on our CDC HRSA advisory committee, so she advises government on what we should do, particularly around issues around aging. So welcome to the podium, Meredith.
Great, thank you for that introduction, Laura. And I'm gonna make sure I can advance the slides here. So these are my disclosures. So what we're going to talk about in the next half hour is around the role of screening for neurocognitive impairment, and I'm going to just say out front it's still controversial. And then what I really want to do is focus on some practical strategies that you can do if someone comes to clinic and is presenting with cognitive symptoms. Before we get into that, though, I'm going to give an overview of some of the changing terminology and some of the advancements that are occurring right now in the world of neurocognitive impairment, in particular Alzheimer's disease, and how that may or may not apply to HIV. And just to note, I know Dr. Valcour gave this talk last year. He was one of my first research mentors at UCSF, so I was a little intimidated taking over from him. But I realized I have my own unique perspective, and part of that is because I left San Francisco and UCSF to move back to Indianapolis and take a position at IU because I am the primary caregiver of my dad who has Lewy body dementia and Parkinson's disease. And so I know firsthand about this issue. And so keep that in mind as I have some unique opinions that I'm happy to also talk more in the discussion. So the 5 M's of geriatrics, this is a way to help remind you of what you should be thinking about with your older patients. And in particular today, we're focusing on mind. So we're going to talk specifically about neurocognitive disorders and dementia. But even when you're thinking about mind and dementia, you have to distinguish it from other conditions like depression, although there is significant overlap with depressive symptoms and neurocognitive impairment, and also distinguish it from delirium, which is an acute fluctuating process of inattention. And I think delirium in particular, as someone who has been caring for someone who has been in and out of delirium as well from hospitalizations, I think is something that is less talked about and really critical to people's overall quality of life. And so if we think about the other M's, they're also going to come into play as we focus on mind. That's going to include medications and the role they can have in cognitive symptoms. If you're assessing someone with changes in cognition, it's actually really critical to get a sense of their mobility and history of falls, as that can point to certain etiologies. And then as well, this is not occurring by itself. Often the person who may have cognitive symptoms has multiple chronic conditions, and I think we really have to think about it as a multifactorial process. And then of course, what matters most is going to come into play as thinking about treatment options, and even if someone wants to be evaluated for cognitive concerns. So before we can get into screening and evaluation, though, you need to understand what is the normal changes with age that occur in the brain, because there is a lot of misinformation out there. And I think the first critical thing is that it's not all decline. Too much in the United States, we think of aging as all decline, but that actually some parts of memory can improve with age. For one example, vocabulary improves with age in studies. What are some of the subtle declines that do occur with age and cognition? Slower processing speed. So it may take longer time to get through a new task. Complex tasks are more difficult when there's a lot of distraction, and that's because there are attentional changes that occur with age. So it can be harder to focus if there's a lot of other noise in the environment. And there can be problems with occasionally forgetting the word or recall somebody's name. It's not an issue of recognition, though. So you should recognize, you might be watching TV and you're like, oh, that actor, and you know them, you know you've seen movies of them before, or a friend that you recognize, you just don't remember their name in the moment. So those are normal examples, and they do not interfere with your daily function. You are still able to do all the things you want to be able to do in your day-to-day. So how do we define neurocognitive disorders? So there's a spectrum, and I would say that spectrum is evolving to now where we're also considering in a spectrum asymptomatic or pre-symptomatic in the case of Alzheimer's disease. But mild symptoms are just that, mild neurocognitive disorder, mild cognitive impairment. Someone has milder symptoms, but it's not affecting their day-to-day activity. So you need to do that functional assessment in order to understand. Whereas a major neurocognitive disorder, which I'll be referring to as dementia from here on out, is actually there are changes in people's ability to do their daily activities. And right now, I think I'm not going to go into this, but it's just important to point out that right now there is a major shift occurring in the field of Alzheimer's disease, which is whether Alzheimer's disease is a biological definition or a clinical definition, this kind of syndrome. And the Alzheimer's Association and the NIA came out with research guidelines a few months ago defining Alzheimer's disease now as a biological condition based on biomarkers. That is not yet for clinical care, but there is a lot of discussion as how that is going to apply to clinical care. And I've included some articles here, including some that have just been published this month on a response to that and what that is going to mean going forward. So function, again, you can't ignore all the other M's, even if we're just focusing on mind. You need to know and be able to take a functional history. These are just asking, the easiest way is often just asking about daily activities. These can be IADLs, and often that is sometimes the first things that go. Someone's having cognitive symptoms. It could be trouble managing their medications or paying bills as they used to. Someone who has multiple deficits in activities of daily living, like needs help bathing, dressing, basic tasks, is someone who needs 24-hour care. And again, just asking about mobility and falls in particular when evaluating cognition, because that can suggest Parkinson's or other etiologies. What's really critical, and I think one of the big challenges in clinic that I face, is having someone who can corroborate that history. So having a family member, a caregiver who can say what is actually going on and confirm, is that person really struggling with this? Or, you know, one of the challenges in dementia is, if you ask my dad, he'll say he's fine most of the time. He doesn't necessarily acknowledge that's part of the dementia process. So having that corroborative history is so hard when so many of our patients live alone and are isolated. And so thinking of other care team members, whether if they have a case manager or a neighbor or anyone else who can provide some additional context into what's really going on. So along with some of the changes in defining Alzheimer's disease, I would say there's also been some debate in defining HIV-associated neurocognitive disorder. So I put here some of the timelines. So 1991 was the first time that HIV-associated dementia and neurologic manifestations of HIV were really categorized. And then in 2007, and what's been the most predominant criteria are the Frascati criteria, which were actually designed to be research criteria, but have become clinically used. And the three categories are asymptomatic neurocognitive impairment, mild neurocognitive disorder, up to HIV-associated dementia, with the asymptomatic being as what it sounds like, someone has impairment in 2 or more neuropsychiatric testing domains, but no symptoms. And that is some of the controversy that is now around some of the new criteria that are being proposed in 2023 from the International HIV Cognition Working Group, and this is the concept around HIV-associated brain injury. And actually, the guidance that came out was meant to be 6 recommendations shown here. They are all meant to be points of discussion. So I think we're going to see more in the coming years about how we're using the Frascati criteria or how we're using these new recommendations around HIV-associated brain injury I think some of the main concerns of the newer recommendations are that the Frascati was overdiagnosing people, and they're trying to get away from using asymptomatic and focusing on people who have symptoms, also taking into context a global perspective and where people may not have access to neuropsychological testing, which includes part of the United States as well, and thinking about how that testing should be interpreted in a large number of cultures. So what about HIV-associated neurocognitive disorder now? So prevalence estimates vary between 30 and 50%. Some of those are older studies that may not include everyone who was virologically suppressed. I think more recent estimates are, again, leaning more towards that lower end, maybe 30%. And again, whether you're using Frascati criteria or not. And the classical presentation of HIV-associated dementia had a lot of subcortical features, meaning motor symptoms, so almost like Parkinson-like features, tremors, gait problems. And now we see milder forms, which include still some of the executive function, attentional deficits. So that difficulty in multitasking is something I always ask people about, because we see that a lot in hand. You know, are they having to reread things, not able to follow along in concentration and conversation more just because they're not able to totally attend, or they're slower in processing. And so one of the critical challenges for our field right now is, well, now that many of our patients are in their 60s and 70s when they're becoming at risk for neurodegenerative disorders like Alzheimer's, how are we going to distinguish between Alzheimer's disease and hand? In particular, as we've had antiretroviral therapy, the presentation has changed a little. We're seeing milder forms. Sometimes testing can even reveal kind of cortical deficits and not always the subcortical picture. And so I'm not going to go through all of this on the side. I've put some articles at the bottom that go into some of the differences, but really just to point out some of the symptoms I mentioned around the slowing, the attention, the executive function, and that hand tends to be a fluctuating course. Everyone is not going to always progress and worsen, and I think that's important to discuss with patients. It's not like Alzheimer's disease, which is slowly progressive, and what is frankly what most people are worried about when they come and see me in clinic. And then we're going to talk more about some of the new biomarkers and imaging that's available, and I think we have to understand how that would apply in people with HIV, because there are some differences. We know that amyloid plaques do appear in the brains of people with HIV, but they may be more diffuse than sort of what we think of in classic Alzheimer's disease plaques. So now the question, well, should we be screening people? And I think this came up in the context of there's a lot of buzz around these new anti-amyloid drugs, and we should be thinking about getting everyone on treatment, and there's all this buzz around biomarkers. And I would argue there are still things we can do no matter what stage of dementia someone is at. There are things we can be doing to improve their quality of life. And so I would argue that we shouldn't actually just be thinking about screening in terms of the newer treatments. I think that is something that is changing the conversation around Alzheimer's in particular. If you look at the USPSTF, which is what's shown here, they say there's insufficient evidence to recommend for or against screening in asymptomatic people. So that's one of the key distinctions to make here. Are we talking about screening? If I think of screening, I think someone who has no symptoms. And we're gonna send them for a colonoscopy, or I'm gonna do this mini cog now. And that is very different than case finding as the person who comes in who's telling you they have a little bit of cognitive concerns, or maybe you've noticed some changes over the time as you've been following them and something isn't adding up and you want to assess further. So asymptomatic screening, there's insufficient evidence. Some would argue in favor because not only could we maybe identify people earlier? We know we tend to underdiagnose cognitive impairment and dementia in clinic, but if we could diagnose people earlier, would that mean they might be eligible for some of the treatments? The other argument is it can help people in care planning. And I think we could say even non-pharmacologic treatments have made a big change in the last few years, and they're more comprehensive dementia care models, for example. Arguments against is that you could actually identify someone who has, positive amyloid in their blood and has no symptoms and is not going to go on to have Alzheimer's, and just the anxiety that can happen around being told you may have this predisposition or that you may be at risk and you have no symptoms. So I'm talking a lot about the new drugs in Alzheimer's disease, so I just wanted to give a quick overview. So there have always been anticholinesterase inhibitors like donepezil. There's been memantine or MNDA receptor antagonists. These have so-so data, although I will say it depends on the type of dementia that people have, but in Alzheimer's disease. And then beginning in 2021, we've now entered this new era of amyloid-modifying drugs, anti-amyloid antibodies. Aducanumab is already gone. That's a whole other story about the data or lack of data behind it. And now we have lecanemab, which is more available, and then recently improved donanemab, which is not rolled out yet everywhere. It was just approved by the FDA in July. And what's really important is that these do represent a major, they're reforming and maybe confirming some of the amyloid hypothesis around Alzheimer's disease. But it's a major commitment here. It's an every 2-week infusion for lenacapavir and I'm mispronouncing them all, but lecanemab. But every 2 weeks you go in for an infusion and you're going to have MRI surveillance because there is real risk of the treatment, including these amyloid-related imaging abnormalities called ARIA. And interestingly, the people who are maybe at highest risk of having these ARIA complications are the people who have 2 copies of the ApoE4 allele. So probably that highest risk of Alzheimer's may also be the highest risk of having side effects. This is not a cure. The goal of these drugs is to slow progression. And at least with the latter 2 agents, it does seem that they do slow progression. And that may be important to some people. Again, it's going to be a discussion of the commitment, the risks, as well as there's a lot of exclusion criteria here. And I point out immunosuppression does not mean immunosuppression like HIV. It's being already on another monoclonal antibody, like for rheumatoid arthritis, for example. But the one concern I have in people with HIV is this idea of microhemorrhages, and they go really into specific criteria around the grading and extent. And if you get an MRI of many of your patients, if you have of a patient with HIV, the MRI almost always shows white matter changes, whether it's in a periventricular pattern like possible vascular disease, or sometimes they're just discrete white matter changes. And this may end up being exclusionary for many of our patients. And so there are lots of things to think about, as well as they should not be on anticoagulants. So, maybe not the new drugs should be guiding our decisions around treatment and around screening. But what if you decide to screen, or if you decide you're going to evaluate someone's symptoms further, what kind of tests can you use? Especially if you've got a 15 to 20 minute visit and you have a whole lot of patients waiting behind you. What are the first things you can do? So if you decide that you're going to screen, you can simply ask about memory or thinking. Do you notice a change in your memory or thinking? You could do a mini cog, which takes about a minute, 3-word recall, and a clock draw. And in people with HIV who might have some executive function, if they have hand, the clock draw does get at executive function a little. And that works actually as kind of the model of the Medicare annual wellness visit. If somebody has symptoms, I would probably go with a slightly longer test that takes closer to 10 minutes. I pull on here the MoCA, which is the test that I use right now. It is not a perfect test. It's about 60 to 70% sensitivity for HIV-associated neurocognitive disorder, but it is better in terms of sensitivity for hand if the MMSE and the HIV dementia scale, which was developed in the 90s and is really only good at detecting severe cases of AIDS dementia. So the MMSE, the MoCA, HIV dementia scale have all been validated in hand and also in Alzheimer's disease and other neurocognitive processes. I know in Kaiser Permanente in Northern California, they are looking at slums right now as part of their case finding definition in the electronic medical record. And I would point out here on the MoCA, one thing that is one of the critical points in helping to think about whether this could be Alzheimer's or hand is actually if you look in the delayed recall and there's the option of cues. And that is where you can get a little bit of a sense whether someone's having a problem with retrieval, which is more along the lines of an HIV-associated neurocognitive disorder, or whether it's more an encoding process, which tends to fit more with like an Alzheimer's disease-like picture. And so the person who has more hand-like symptoms will be able to recall the words when you give them a hint, basically. And the MoCA does, I know there's a lot of concern about the MoCA costing money. You can still use the MoCA. It's not a copyright issue like the MMSE. However, there is a training cost. And it is, I personally have not done the training, but I think it is probably worthwhile. There are institutional discounts, especially if you're going to have multiple staff do it so that it can be standardized and make sure that it's being asked in the same way of all patients. So I've alluded a lot to these biomarkers. It is not ready for screening right now, but I think it's coming. And I think we're really going to have to think through how we would use this. Are you going to send someone for a blood test and then tell them over Epic that, oh, you have amyloid in your blood, you might have Alzheimer's? So we're really going to have to think through some of the ethics around this. And so right now, it is not meant for asymptomatic people. You can order these tests clinically if someone has symptoms, but I would really argue unless you feel comfortable with this and unless you have a dementia specialist to help you with the evaluation, that's really right now the role for this. And there are actually 2 studies that came out earlier this month in JAMA. One is looking at using some of the commercially available biomarkers in a primary care setting in Sweden, and the accuracy of diagnosis went from 61 to 90%. So I think there is going to be a role for these, but there's a lot to learn, and I have not had the time to go through all the minutiae of these studies. Amyloid PET, similarly, Medicare actually now covers this, which was not the case when aducanumab first was approved. So this is going to facilitate having the amyloid PET scans in order to go on for consideration for treatment. But it's important, again, that there are false positives, and false positives occur more with age. It's not just amyloid in the brain that contributes to Alzheimer's. So that was overview and some of the controversy around screening, but what I really want to do is, like, what can we do now? So you're in clinic, a 70-year-old man comes in, he has well-controlled HIV, as many of our older patients do, undetectable viral load. I highlight his age as 70 because I do think that's an important initial kind of thing in your mind to think through. So he could be at risk for maybe other neurodegenerative processes, where the person who's 55 who comes and see me in clinic, I'm already sort of thinking this is more likely maybe HIV related. The occurrence of dementia before age 60 is very rare. Most of the cases are frontal temporal dementia, which if you follow Bruce Willis, that is what he has been diagnosed with. But also, in addition to just his age, you think about his other comorbidities. So he has hepatitis C, he's had a past use of substance use disorder, he had injected methamphetamine and also heroin at various points. Vascular risk factors, probably some metabolic, he has a BMI of 30 and diabetes. And then you can see some of his medications there. So you may, if you've decided you're going to screen, again, you can ask about changes in his symptoms or if he's noticed any symptoms. And I would at the same time ask permission to talk to other people if there are other people in his life. Or if he's endorsing symptoms, you can start this process and asking about some of the executive function or other parts of memory, including language or behavioral changes. And this is where if you have a continuity relationship with your patients, as so many of you do, it's looking and observing, has there been a change? Are they missing appointments more? Are they dressing differently? Is there behavior change, or they're more apathetic? So things like that can also be a sign of cognitive changes. And what's really critical, and this is from the Lancet the Lancet Dementia Commission. I bring it up because they are doing an HIV and Aging Commission that will be convening, started this year and will be convening the next 2 years. And so I'm really excited about what we will see come out of that work group. But in terms of dementia from the Lancet Commission, many of the things that can contribute to dementia are modifiable and preventable. And I think that's one of the key takeaways today. So you can manage vascular risk factors. You can get someone hearing aids if they have hearing loss, or make sure they've had vision screening. Making sure someone is engaged in physical activity, social activity, cognitive activity, not just that they have to spend money on brain games, but that they're actually engaged in learning new things or training their brain. And so these are some of those things. If I think of that brief case I just shared, I ask everybody about sleep, especially sleep apnea symptoms, snoring. I have had people's symptoms go away completely after they got started on CPAP. So it's really important to think about these other modifiable things that can contribute. We're going to talk more about medications, and I think we also have to really recognize that some people with long-standing substance use disorders have more vulnerability in general. Their brain has already sustained injury. Same thing with traumatic brain injury, asking about history of head injury. And the social isolation, which I think is so, unfortunately, so common in many of our older patients with HIV, and how can we be thinking about addressing that? Now, I did put here at the bottom, there are still rare cases of CSF escape, which means even though someone has undetectable viral load in their blood, they have a high viral load in their CNS. Those cases are not subtle. Usually it's a rapidly progressing case, abnormal neurologic exam. The few times I have ordered LPs on someone, it's because it's a rapid change. Their behavior has dramatically changed as well. And in those cases, that may be where you might actually modify antiretroviral drug therapy. So just a note on other medications. So medications with cognitive effects, many of these are on those potentially inappropriate medications in older adults, so things like the Beers list or the stop-start criteria. And there's a reason for that. So benzodiazepines, anticholinergic medications, especially antihistamines, including the antihistamines people don't know they're taking, like when they go and get Tylenol PM over the counter, which is basically Benadryl, or the prescription sleep agents, and a lot of the overactive bladder drugs are also highly anticholinergic. And sometimes there are behavioral strategies that can help people manage those symptoms. So in thinking about deprescribing something, I always think about what's an alternative treatment, and again, always thinking about those non-pharmacological treatment options. Well, so that's maybe medicines to avoid to support brain health. Well, what about a multivitamin, or like those ads on TV for Prevagen, which my patients ask me about every clinic visit? So one, when you're doing a workup, if you think back to school, sending a vitamin B12 was part of the standard workup for cognitive symptoms. So you should do that. And if someone's vitamin B12 is low, they should be on replacement. Some of my colleagues at the Memory and Aging Center at UCSF would argue their level should be a little higher. So maybe more closer to 400 or higher, not using that cutoff of 200 or lower. And then there's mixed data on diet. The MIND diet was developed with a Mediterranean diet combined with the DASH diet. There did show some promise in slowing cognition. There was a recent trial, though, in preventing cognitive symptoms. It did not have any evidence, but in slowing, maybe. So I think the evidence is mixed, and I would say that it's a little bit mixed on multivitamins too. Last year and earlier this year, the Cosmos study, which I think is cocoa supplement and multivitamin outcome study, out of Brigham and Women's Hospital, looked at the effect of getting a multivitamin versus placebo on some global cognition scores as well as episodic memory. And there was some suggestion that at 1 year and also over 3 years that the group on the multivitamin did have some improvements. Unfortunately, for those of us who like chocolate, the cocoa supplement did not have any benefit on cognition. The table on the right is actually from Dr. Helmuth, who works in this area, also at UCSF, in a paper they had in JAMA about the marketing of supplements for brain health, the Prevagen and the Neuriva, and I forget all the other things that are out there. And they are expensive, and I have patients who spend a lot of money on supplements, of which we know the FDA does not test or review. We don't know what people are necessarily getting when they take those pills. And so they have a patient information page that I encourage you to take a look at. I tend, I know why people are wanting to take them, and so I tend to have a discussion. And again, a lot of this is shared decision making, but when people are paying a lot of money out of pocket, that's when sometimes that can be what can motivate them to maybe discontinue and try something else. So coming back to your clinic, so I think really some of this is setting the expectation that the first time they come in and tell you about cognitive symptoms, or maybe you're screening and discover something might be going on, is that it's going to take a little bit of time. And that's what I do when people come to see me in consults, and that I want to rule out all these other things, and we're still going to take this holistic approach to optimizing your brain health. And we're going to talk about brain health in a couple slides, but just this brain health approach can really change some of the framing. And it's going to be working with them to determine priorities. So in the case of our 70-year-old, maybe it was stopping the hydroxyzine first. But sometimes people are very attached to their medications. And again, I think of that as like a harm reduction strategy. And then all at the same time working on compensatory strategies. So there's always something we can do. For hand in particular, using lists, calendars, reminders, and avoiding multitasking are all strategies. And I'm over time, so I'm just going to very briefly say brain health, it's these lifestyle approaches that we can support our patients with that have the most data. Exercise has the most data in preventing Alzheimer's disease and other neurodegenerative processes. And as a person who is caring for someone with dementia, I just think we have to also think about non-pharmacologic strategies, and that there are other resources that may support why you want to screen. It's getting patients and their caregivers this help. CMS this year approved the GUIDE program, and I encourage you to go to the CMS site and see if there are participating institutions in your area. It is across the United States and provides care navigators for any diagnosis of dementia. It does not have to be Alzheimer's, so could apply to people with hand. And also there are behavioral strategies. This came out 10 years ago, and now is a whole website and training approach on how to deal with specific behaviors. Again, many which can be resolved by stopping a medication, making a small change in the environment. So I just want to take away, even if we do not have treatments that can cure dementia, or maybe it slows the progression, there is still a lot we can do to support our patients with dementia. And some of that is going to be coming back to the 5 M's. So just in summary, screening is still controversial, but I think I would argue we're at a point where we should really be thinking about screening, and that we can address modifiable causes, and that there's a lot we can do to support people and thinking about their brain health as well as across the lifespan, and helping people to avoid some of the symptoms that they may develop later on. So with that, I'm going to end and take questions. Thank you.
Great, that was a massive summary. Thank you so much for that. That was fabulous. We don't want anyone standing up at the microphone for questions. Pretty complicated topic. So when you have a 45-year-old who comes in and says they couldn't find their car keys yesterday, or just those things that happen, like, how do you help a patient distinguish, maybe not 45, even 55 or 60, that sort of normal aging, that things are, you're not like when you were 24 versus like, how do you make that distinction with patients, and how do you decide at that moment, like, what path you're going to pursue?
Yeah. Is this on?
Yes.
Okay. So yes, I always have a conversation about what is normal with aging and what is not normal, because that, I think many people do not know. And I think many providers, we did not learn that in medical school. At least when I went to school, we did not learn a lot about the normal physiology of aging, and that's beyond cognition. There's a lot of assumptions that incontinence, falls are all a normal part of aging, and they are not. So the person who's occasionally forgetting their car keys, I do ask, how often is this happening? Is it like once, once a week, or is this happening multiple times a day where you're misplacing things and losing all around? And then I would go into more of an evaluation. Same thing, I think when people do get into their 60s and 70s, I am definitely doing more comprehensive, but I do see people in their 40s and 50s because HIV-associated neurocognitive symptoms can occur at younger ages. We don't have as much data on the prevalence. And I think the other thing is now that we start people on earlier ART, I think time will tell what the prevalence is going to be, because we know that people who are started in acute HIV, there's a lot of data from studies in Thailand, even 10 years out, they're not having neurocognitive symptoms. And so I think we have to keep up the work of getting people on ART sooner as well.
Great, thank you for that. Any questions from the audience?
Sure.
Okay, let's start here and then we'll go to you. Right there.
So the data obviously about statins and their cardioprotective effects are great, but some of our patients are asking about long-term use of statins and potential detriment to neurocognitive outcomes. How do you have the risk-benefit?
Yeah, so first I would say for the data on statins only goes up to people age 75. So after age 75, we don't have data. Regarding the study where there was maybe some neurocognitive, I mean, it's association. I think we still need more studies to confirm that. Only in like my patients who already had, advanced dementia, upper ages, and these were not people with HIV, that's when I would have the conversation about stopping. I think we don't have enough data in people with HIV and how much that is, other than I think we have shifted around just the treatment of vascular risk factors, like being more aggressive with blood pressure and lipids in general, in terms of preventing cognitive outcomes.
And I just wanted to say I really loved what you said about brain health, because I try to do that with all my patients. Not only do I talk about their physical health, but I say, what are you doing to keep your brain active? And I talk to them about, using a mouse with their non-dominant hand, or turning off their GPS and trying to figure things out that way. And I just think it's an important reminder to address this frequently with patients, because it's easy to get into a routine without stimulating your brain.
Yes, absolutely. And I think with COVID and when everyone was in lockdown, saw many people with decline in their cognition, not because they had developed a neurodegenerative disease, but because they were not engaged in their usual activities and did not have that social interaction they had before. So I think we've had a real example of that.
One thing Victor Valcourt said a couple of years ago when he was here is that he doesn't want people playing those smart games. He wants them talking to other humans, where you've got to read facial expressions and body expressions and listen to what they're saying and respond to them. And it's like a whole different level.
Yeah.
So I think that's what you were getting at there as well, right? That human interaction.
Yes, absolutely.
Yes?
Hi, I've had a few patients who are in their 30s or 40s and they've had a history of substance use. Now they're sober, and they've just asked me, well, can you just check if I have any cognitive decline? Almost to see, like, well, how much should I use again, or how much brain damage have I caused?
Yeah, so I mean, there's no study that has looked at that. But I mean, I will say, I mean, I have seen people who are actively using drugs who maybe had a parent with Alzheimer's who are very concerned, and sometimes that has been the motivation for them to decrease their use. Or I had someone else stop drinking, because we have to also consider alcohol and its effects on alcohol-related dementia. So, I mean, I think that's where having the brain health conversation about all the things you can do to support. And if you do think there's actually real symptoms there, I mean, you could do an assessment. Yeah, absolutely.
Are there scenarios where you do ApoE testing for people who have a strong family history?
Sorry.
We missed the first part.
Yeah.
A little slower.
Sorry. Is there, do you think there's a role for doing ApoE testing in people who have a strong family history of Alzheimer's disease?
Yeah, so that's again a shared decision making, and I think that's one of the controversies with some of the new drugs is that the people who might have the strongest risk, most benefit, have some of those side effects, and doing that testing to see how high risk they may be for the side effects of lenacap. I can't say it either.
We know which one you
Yes.
mean, not lenacapavir, the other L
Lecanemab.
word. Okay.
That the controversy there too is then that has potential, if they are found to have 2 copies, that has potential implications for their children as well. And so I think it's a discussion, and that's what I think a lot of these things are. It's shared decision making, which I know came up on the ART panel, but I think that is absolutely critical with cognition.
Great. They got another? This is great. I like being at the microphone. This is working really well.
Is there a time window following COVID infection where people are experiencing some brain fog and things that you would wait before doing screening?
Yeah, I'm thinking of some of the long COVID studies I was briefly involved in. And I mean, I think people can still have symptoms, for sure 6 months, a year out. And I would maybe wait a year in some cases, especially in older ages, just because multi-hit at least 6 months. And whether that's completely evidence-based, I don't know. Same thing if someone has a really high viral load, HIV viral load, and they're having cognitive symptoms. That should improve when they get undetectable, but I usually wait 6 months to a year before I'm gonna dive into a deeper assessment because I wanna see how much they'll regain from being suppressed.
Do you have any good recommended validated tools for non-English speaking patients?
Yeah, this is one of the challenges, and I think part of the point that the international working group is getting on around the criteria for hand. So the MOCA has actually been used, and you can download in multiple languages. I regularly use it in Spanish. I have tried it, and I think some of it is who you have as an interpreter as well. That's one of the things where having an in-person interpreter is really critical. It can be hard over the phone. I have done it, but it's harder, as well as you could use video translation. But the mini-cog has also data in multiple languages, and I know they're working on the TabCat and others. So many of them have been, but you need to look at which languages in particular have been studied.
Great. Well, thank you so much. It's been a fabulous presentation. Really appreciate it. Thank you.